Thanks so much, Professor Rossano Shab, for the kind invitation. It's always a pleasure to come here. This is the list of my conflicts of interest. So if we look at the story of the pharmacological treatment of patients with heart failure over time, I think until a few years ago, we have made two different stories, one of success for heart failure with reduced ejection fraction and one of failure for patients with preserved ejection fraction. But this has been changing a little bit over the last few years, in particular when it comes to heart failure with preserved ejection fraction, with trials having been demonstrated improve outcomes with SGLT2 inhibitors and more recently finerenone, and we will see this later. But starting with heart failure with reduced ejection fraction, I think that the benefit associated with quadruple foundational therapy, as you see in this very nice meta-analysis of randomized controlled trial, is quite evident. So here you see that whether patients receive quadruple therapy consisting of ARNI, beta blockers, MRA, and SGLT2 inhibitors, this translates into 60% reduction in risk of all-cause mortality. And similar risk reduction, even more, would be observed whether patients are assessed for cardiovascular mortality or heart failure hospitalization, as you see on the right. And there is even a 70% reduction in cardiovascular mortality in this meta-analysis with quadruple therapy. So it's very clear that whether patients receive a pharmacotherapy characterized by multiple drugs, this actually translates in better outcome. And this is very nicely illustrated in our guidelines, as you see on the left, the European ones, on the right, the American ones. They consistently report that quadruple therapy, so ACE or ARNI, beta blockers, MRA, and SGLT2 inhibitors have a class 1 recommendation. And on top of this quadruple foundational therapy, actually more treatments can be used based on the specific patient profile. For example, in patients who might have LBBP and in sinus rhythm, we might consider a CRT. There might be also indication for ICD in patients with for prevention of sudden cardiac death in specific cases, as you can see here, or the treatment of valvular heart disease. So foundational therapy for all, and then targeting specific patient profile for additional therapies. And we should not forget also the use of vericiguat in patients with worsening heart failure. So when it comes to heart failure with reduced ejection fraction, I don't think there is very much to say. Very clear treatment, clear guidelines, consistent across different countries. When it comes to HFpEF, so preserved ejection fraction, the story has been a little bit more complicated. So you see here reports several trials on several different treatments. So you see PEP, CHF, and the SHARM preserved, and the I-preserve, actually no ACE inhibitors and ARP. All these trials were neutral when assessing perindopril, candesartan, and irbesartan as compared to placebo. You see a meta-analysis on beta blockers in patients with HFpEF, and there was absolutely no difference in risk of mortality when it came to comparing beta blocker with placebo. The TopCat trial overall was neutral, testing spironolactone as compared to placebo. And the Paragon HF trial was as well neutral, although p-value was quite close to statistically significant. So this was the situation which was shown until a few years ago, which has luckily for our patients very recently changed. And the first foundational therapy for heart failure with preserved ejection fraction, using a kind of approach one fits all, so one treatment which might fit all the different profiles of patients with heart failure with preserved ejection fraction, has been the SGLT2 inhibitors. This is a meta-analysis of the major trial, clearly showing that in patients with preserved ejection fraction, dapagliflozin and empagliflozin had a class effect in improving the primary outcome of the trial, which was cardiovascular death or heart failure hospitalization, as well as the other outcome. A major one was, of course, heart failure hospitalization, which in the individual trials drove the reduction in risk of the primary outcome, since it was one of the outcomes used in the composite outcome, which was the primary outcome of the trial. So the deliver and emperor preserved paved the way actually for having SGLT2 inhibitors, as we do have today, as the first foundational therapy in patients with heart failure with preserved ejection fraction. And more recently, there has been actually coming back of mineralocorticoid receptor antagonists to HFpEF in a different way, in the form of non-steroidal mineralocorticoid receptor antagonists, meaning finerenone. I must say that this might be another treatment, one treatment fitting all the HFpEF profiles, since the trial was quite broad and enrolled a quite broad population in terms of differences in patient characteristics. Very successful trial. There was a reduction of around 15% risk of the primary outcome, which was cardiovascular mortality or total heart failure hospitalization. Patients with mildly and preserved ejection fraction were enrolled, so more than 40%. There were some criteria for enrichment, which you see reported in inclusion criteria, and patients with an eGFR less than 25, a potassium more than 5, and a blood pressure less than 90 were excluded. So the trial was successful, primary outcome was reduced. It was mainly explained by the reduction in risk in heart failure events. We should not forget that there is still hyperkalemia with finerenone. As you can see, finerenone was associated with a double of hyperkalemic event as compared to placebo. So it's still something to be considered. When pooling actually data with, in this meta-analysis with other trials on MRA, you can see that the point estimate for fine arts and top cut was quite similar. So the question is to see whether the effect on outcome was mainly driven by, in the fine arts, by the fact that the MRA which was tested was a non-steroidal MRA finerenone, rather than probably the top cut was neutral for some other reasons. So we need more evidence to understanding whether there is a class effect with MRA in patients with heart failure with preserved ejection fraction. And this evidence is coming soon. There is this pragmatic trial ongoing in Sweden, a registry-based randomized controlled trial, HFpEF, which is actually testing spironolactone versus placebo in patients with mildly reduced and preserved ejection fraction with primary outcome cardiovascular mortality or heart failure hospitalization, and this trial will deliver next year. However, patients with heart failure with preserved ejection fraction are very heterogeneous. You can see whether you apply clustering to this population. Actually, you can identify very different populations at different risk of outcome. And whether you perform post-hoc analysis of neutral trials, which is something hypothesis generating on in these different clusters of patients with HFpEF, you might see that even ACE inhibitor, ARB, and actually MRA, spironolactone, might work in specific clusters. For example, here you see here that whether you reanalyze the HFrEF in a subgroup of patients with high rates of obesity, diabetes, hyperlipidemia, and renal function, so a more cardio-renal metabolic profile, actually irbesartan might reduce the risk of cardiovascular mortality or heart failure hospitalization by actually 28%. And whether you apply the same strategy to the top cut trial in one of the phenotype, the P3 characterized by obesity and diabetes, actually you might see once again the spironolactone might significantly reduced by 25% cardiovascular mortality or heart failure hospitalization. So this means that probably for some treatments we have been wrongly testing actually patients with preserved ejection fraction. We just used too broad population, aiming to demonstrate that one treatment was fitting all the phenotypes, but probably this doesn't work for all the phenotypes. Probably it works, sorry. Can we go somehow back? Hello? Yeah. Thank you. Okay, this delayed even more the presentation, but it's okay. Whether you apply you want to test treatments in very broad population, probably that treatment might not work in all profiles. And therefore, together with the European Society of Cardiology, we identify a different approach to try to assess patients with preserved ejection fraction, which is actually patient profile, and trying to understand whether treatments might work in specific phenotypes of patients with preserved ejection fraction. I think you have been speaking recently about obesity during the meetings, so the HFpEF trial demonstrated that semaglutide might work in patients with preserved ejection fraction and obesity. So this is a treatment targeting a specific phenotype of patients with preserved ejection fraction. It has been done actually the same for other treatments. Okay. So we have also similar results in obesity on tirzepatide. Actually, these are the results of the SUMMIT trial, very recently showing that tirzepatide improved outcomes, so cardiovascular mortality or heart failure hospitalization in patients with preserved ejection fraction obesity. So a different approach to treat heart failure with preserved ejection fraction, coming to address specific phenotypes. Another profile is characterized by iron deficiency. These are the results of the HFpEF trial, where it was shown that ferric carboxymaltose in patients with HFpEF improved functional capacity in terms of 6-minute walking test in a very small trial, and more outcomes data are indeed needed for this. Another phenotype is the one characterized by hypertension, with clear evidence that whether we treat patients with hypertension for hypertension and they have also heart failure, this leads to better outcome. So we have been changing our way of interpreting the treatment of heart failure with preserved ejection fraction, as well with having some foundational therapy, which is dapagliflozin, finerenone, which might fit all the treatments, and then targeting specific phenotypes as the one on obesity, iron deficiency, and so on. When it comes to heart failure with mildly reduced ejection fractions, just to make a long story short, you might see that all the same treatments which work in heart failure with reduced ejection fraction will work also in heart failure with mildly reduced ejection fraction, since these two phenotypes are very similar. And very recent results from the FINE-ARTS trials also showed that finerenone works in HFrEF as in HFpEF. So the treatment for HFrEF has become very much richer over the last few years. So this is, I think, what we will see very soon in terms of guidelines for these phenotypes. Of course, when it comes to understanding the treatment for HFpEF, HFrEF, and HFrEF, it's important not to forget that we do have treatments improving outcome, but one major limitation is that they don't get often implemented in clinical practice. So this is actually a call to try to apply the evidence we get from clinical trials and guideline recommendation in our day clinical practice. Thank you.